we had part one of the corrosive esophageal injuries. That is the acute injury part we discussed yesterday. So, little bit touching upon what we discussed yesterday. I am presenting that one through few of the slides. See, in India, the Honorable Supreme Court has a very clear-cut directive regarding how you should sell these acids, sell these corrosives, and how you should purchase, how they should be handed over, or stored, everything. But and there are also constant educational efforts from the government as well as the social service organizations to educate the people regarding rather how not to misuse these things. But in spite of that, it is a sad state that we used to get plenty of cases here in our institute, and I know they are everywhere in India. It is a global problem, as Dr. Vikas has said. Just the red line corresponds to those areas which are sporadic with this problem. And in India, out of all the corrosive injuries, the out of all the chemical injuries, be it poison, the poisonous snakes, rodenticides, etc., drugs, chemicals, the corrosives, in true sense, those alkalis and the acids, they constitute about 27% of the cases. And it is estimated that out of all the suicidal attempts, 28% of them are because of the corrosives. What are corrosive? Corrosives are chemicals causing tissue injuries on contact, and usually they do damage when they are in high concentrations. The pH less than 3 or alkali side more than 11. Caustic, you may hear these terms caustic and lye. Caustic, according to the dictionary, is any chemical substance that on contact causes injury to the tissues. Lye is mostly used in Western countries. These are strong chemicals of sodium hydroxide and its analogs. The mostly the what we are getting in India are acid injuries because of maybe easy availability, and we say that toilet cleaners are the commonest of all, but say the toilet cleaners are acidic, whereas the floor cleaners could be of the same company, could be alkali. So mostly these are 10% hydrochloric acid, sulfuric acid, phosphoric acids, which are ingested. And among the alkalis is that the drain cleaners which are mostly used. We can get battery induced injuries for acids, also the alkaline batteries. See, the mechanism and the pathology all could be initiated by regeneration of the reactive oxygen species that's shown by the Turkish group in two of their publications. And this leads to thrombosis of the vessels, congestion, and necrosis, which can occur within seconds. Within first 3 days, these steps which are shown in blue color can happen. A scar formation in acid because of coagulation. There is a thick scar formation. A scar, we say, as we the same injuries. The pattern is same as we see in skin burns in our surgical practice. And then there occurs infection and inflammation, mostly bacterial inflammation, formation of the granulation tissue, ulceration, and perforation. And then the reparative stage starts. The fibroblasts are laid down, and repair continues up to 10 days. And over that, either epitheliation can occur, or there could be further cicatrization or scarring. This mostly proceeds for about a month. The strictures can occur within weeks, mostly occurring within third month or fourth month, and they may continue to occur, progress up to 2 years, even more than that. We will discuss about the incidence of carcinoma today in later part of our discussion. Now, for the students, it's a stock question that what is the difference between the acid injuries, alkaline injuries, but in actually clinical practice, the volume that is being taken from the acid sides and the alkali sides, ultimately the effects are more or less similar. It all boils down to what is the grade of the injury that is happening to these people. The acids coagulates the proteins. The alkali liquefies by damaging the proteins as well as the fats. Both produce heat. Alkali produces more heat, and acid forms a scar. Alkali causes thinning, so there's more chance of perforation and deeper injuries. The duodenum is involved more or less similarly identically in both the cases. Acute complications are also could be comparable in both the injuries, and the mortality rate is usually 12%, 12 to 15% in both the groups. The outcome is usually poor if the injuries are associated with bleeding. If there is, we discussed about the endoscopic grading. If there is grade 0, 1 or 2A, there is almost no chance of formation of a stricture. As the grade becomes higher and higher, the chance of forming stricture becomes higher, and by the time we reach grade 3, it becomes 100%. There are factors which which can affect the severity of the injury. The four common factors are the pH, the concentration, the volume present, and the duration of the contact. Acids, which are mostly available in solid crystal forms, they get stuck to the esophagus and cause more damage to the esophagus if they are in crystallized form. The duration is also important in, as Dr. Vikas had shown that in mouse models, it was shown that 22 point, if the alkali is 22.5%, if it touches for 10 seconds, there would be transmural necrosis. And if it is 30%, and even within a second, it can cause transmural necrosis. So these are the agent factors. Then the host factor would be if there is a full stomach, there is a chance of protection, versus if there is an empty stomach, there is initial pylospasm and the acid can remain there or the corrosive can remain there, causing more damage. The presence of GERD has been found quite significantly in these patients. It's about 20 to 30% of cases they have GERD, where we find the damage to the lower part of the esophagus or middle part of the esophagus is more. So 15% of these people are usually found to be asymptomatic. Of course, depends upon all these factors. And age, the total leukocyte count, and the grade of the injuries are prognostic factors in these patients. So little bit touching about the history. In 1910, there was first publication regarding this effect of these injuries in 4 cases. And since then, roughly, there are 2 lakh injuries reported per year all over the world. And 13.6% of these poisonings are fatal. Acid is the most common cause, and 47% of the deaths are due to perforation peritonitis. So the in the pie diagram, which Vikas had shown, that the yellow part which is there shows the incidence on the left side, and on the right side shows the mortality. So it's a long, arduous, difficult, stressful journey for a corrosive patient. If he comes like this, and this is one of our cases, who showed the stomach completely burnt up, and then he recovers, he goes for dilatation, and then the further sequelae of this condition, and finally till he becomes fit, it's a really a long journey. So yesterday we were somewhere here halfway stage. That's the acute part. We discussed the role of endoscopy, the endoscopic findings, when to intervene. Dr. Anupam said that there should be ideally a review endoscopy because the initial endoscopy is actually not very informative, or may not be actually correct. And then he discussed more of what not to do. Those points were more important than what to do. There was no established role of EUS, endoscopic ultrasound, MRI, the PPIs, and use of sucralfate in these patients. So, in case of suspicion of the fistula, the oral intake has been delayed. Even if there is a stent, role of a stent, which is exactly not very established, if at all stenting is to be done, it should be done through the to the tracheal side rather than the esophagus side. And Dr. Vikas very elaborately discussed about the indications for surgery after corrosive injury, the procedures which are to be followed, their complications, and how to follow them up. So today, to take us further towards the sequelae, the complications, and till the end point of this condition, I would request Dr. Vikas to carry forward this discussion. Dr. Vikas.
Yeah. Thank you, Dr. Dash.